part of NAEMSE and sharing some of the things that I've been able to figure out as I've become a more experienced EMS educator. I was mentioning to Rio when we were getting started here that I would really hope that this could be a more interactive webinar, and hopefully you could leave here with some actual solutions that you could potentially use, or some changes you can make to your own simulations or scenarios that you have. So if at any point you have a question, please feel free to unmute and ask, or I don't know if you can, but you can raise your hand. We can use the Q&A feature, and I think I've got the chat up as well. So really hope that we can make this interactive and that we can answer some questions or find solutions for you in your own education programs. So we're talking about scaffolding, and really this is something that you're probably as educators familiar with. This idea is that we're going to build on what the learners are learning, like little blocks of information, and then get to a point where we could have this very complex scenario. There's a couple things when we talk about simulation, I feel like I need to just stay out from the gate. I'm very much a train like you fight person. So one of the areas that I think we need to be thinking about, especially when we're doing simulation, and I think across EMS education, but especially the psychomotor aspects and the contextual aspects, which is what happens in simulation, where we take the things we've been talking about in the classroom, contextualize them to a patient presentation, and then have the students do the skills that they were learning in lab, is that it needs to transfer to practice. And transfer to practice is a huge field. There's a whole field of industrial organizational psychology about this, and how do you do training that actually impacts the way people perform in a real situation. And I think sometimes we don't necessarily think about what we're transferring when we're planning our training. So when I think about simulation, I think about scaffolding simulation, even if it's a very small sim. So the Society for Simulation Healthcare's example is just putting a needle into an orange to simulate an IM injection. If that's the simulation that we're doing, we want to make sure that what we're doing there transfers to practice in a way that's safe for our providers and for our patients. And I could give you an example, something that I did all the time that I was not thinking about. When I was coming up through EMT, if you didn't put 15 liters of non-rebreather on a patient in the EMT stations, you failed. And I feel like most of the scenarios are still being done that way, which is a problem in itself, because not every patient needs 15 liters non-rebreather. Luckily, we're no longer testing that way. You don't fail if you don't put that on, but we tend to verbalize that a lot. And I think the oxygen administration, there is some artifact there in sim. We're not going to be using real oxygen all the time. We probably aren't going to be even using compressed gases. So if you were going to put a non-rebreather on, it's probably simulated in a kind of fake way that might not transfer to practice. And because of that, we tend to, as soon as the student puts oxygen on, they're like, hey, did it work? And we're like, yeah, oxygen's great. With oxygen, their saturation comes up to 97. And we are building in this idea that as soon as you put oxygen on, their saturation comes up. When anyone who's been around for a while knows that oxygen saturation is not a instantaneous vital sign. So think about that as, how am I going to plan the scenario, especially things like, how is the oxygen going to increase? Is this going to be in real time? Or are we going to be very specific to say, after 2 minutes, the oxygen saturation is this, or only when the student reassesses? That's the kind of thing that I'm thinking about when I'm scaffolding my simulations. Even if I have to pretend something or do something that's not exactly how I would do it in the field, how am I going to make sure that I do it in a way that will transfer to the patient care environment? So that's the first one. And then the second, this might sound like it's a plug from COA or somebody, but simulation should be integrated into your overall curriculum. I think that there's a misnomer in EMS that simulation is this thing that you do with a fancy mannequin at the end of the program, and that we're like doing lab skills and psychomotor skills, and then we get to simulation. When realistically, we're doing simulation every time we're in the lab. When we are role playing in a classroom and we're doing a case study, that could be a form of simulation. When we're learning on an airway head how to use the intubation equipment, we're simulating that task. And so I think we need to think about how we are using simulation across our whole curriculum, and not kind of thinking it's this like, well, we'll have a sim day at the end once they've learned everything and then they can put it to use. Because simulation is a skill, just like learning to intubate is a skill. And students aren't going to know how to perform in simulation if we just kind of throw it to them at the end. Like, oh yeah, just play your role, just do the scenario, without kind of building that expectation, how things work, how the mannequins work with them, as we're going through the curriculum. So it's twofold, right? We're doing this. We're just not saying we're doing it, right? We're doing it with labs. We're doing it with individual psychomotor skills. And that is part of the curriculum. If we structure it and pull it all together, and we actually are, deliberate with how we've organized skills and simulation throughout the program, we can have more rich learning environments and really cool, like full-blown simulations with standardized patients and moulage and makeup and all the things that we like want to do. We can, as the learners will be able to participate, and they're not going to be lost with, well, I don't know what that mannequin does. I wasn't sure if I was allowed to start an IV on it because, I've not used it before, or it becomes a what buttons to hit, or where do I put my stethoscope to hear the lung sounds from the speaker, but not the compressor from the mannequin. If we build all of that in, they're going to learn how to sim, and then we'll be able to not have that be a roadblock in some of our more complex simulations where we're trying to replace the clinical environment. So I just threw this in here as kind of a reminder to all of us, right? We're using simulation as they're coming up this pyramid from theory into practice, and they're really doing something. So showing how they can, that's part of practice, that's part of simulation. And then doing, when we get to the contextualized things like making effective domain evaluations and really choices about applying protocols and patient treatments and making those decisions and managing our crew, we're going to want increasing levels of fidelity there so that it's going to transfer better or more easily into practice. So that's how we're going to build up our sims. It's part of our curriculum, working towards that ultimate goal that it will be transferred to practice. And so here's where the scaffolding comes into play. We have some kind of learning outcome, and by crafting the way that we are going to deploy these simulations, or what order they're going to come in, those are our learning activities. By giving feedback and assessment and then tailoring the next learning activity to help meet that learning outcome, we're going to be able to really reach into complex skills, tasks, and performance fairly quickly without having unintended consequences of throwing a whole simulation out there that's not there, the students aren't ready for. So when we're building your learning outcome, these are the questions I ask myself, right? So what are the stakes? Is this a high stakes event, like a test? Is this a skills testing? Is it preparing for certification testing? Is this a competency check that's going to determine whether or not they continue to be a full-fledged provider in your agency? I know when I was working in Northern Virginia, that was something that they were thinking about in putting in competency checks for some of our high-risk procedures like surgical airway or IO. It definitely was something that they had us do for new equipment like video laryngoscopes. And you had to pass that if you wanted to maintain your status as a provider, as a medically endorsed provider, right? So is this something that your medical director is saying is a must happen and they must pass? Is it learner appropriate? So are we doing something that's, people might be familiar with this, but I ran this really cool call the other night. It was great. I've never seen this case before. It was so interesting. I want to do that as a sim today. And yeah, that's probably a really interesting case, but these are primary education students. So maybe they're paramedic students in a paramedic program. It's their initial programming. Do we want the one case they see of insert whatever your last cool call here was to be the outlier? Or are these learners, it's more appropriate for them to get the general presentation, and then once they've gotten that down, we can start adding and sometimes it's like this, or this is a rare occurrence, but it's something you might need to know about. So how appropriate is it? Because it could be a really, really interesting case. It could be the coolest call you've ever run, but not great for the specific learner group that we're working with. And then how is it measured? So what evaluation tool are we using? Or how will we even know if the performance in the simulation is good, bad, ugly? Or will we be able to repeat this? So sometimes I think, okay, I'm good. I'll know if I have an idea of what I want the students to do in this sim, and I'll just give them my feedback if it's good or bad. Fine, it's just not replicable, right? Like, unless I wrote down what my expected actions were and then what the main learning outcomes for that simulation were, no one's going to come in and be able to replicate that. So we won't know that this next group of students is going to get the same experience, or if our program is really covering the same things. And I don't mean that you have to do the exact same simulation with every single learner group that comes through your program, but you need to be able to look at your curriculum and see if you're hitting benchmarks, and then how you would be able to defend that. So if you're saying, yeah, my learners will know how to treat a geriatric stroke, then how do you know that? And is it because they did this simulation and they were able to hit these minimum competencies within that simulation? And maybe you have one evaluation tool, like a check sheet that you use for all of your simulations. I would challenge you that that might not be the most appropriate way to really scaffold the way that you're giving feedback to your learners. Because one of the things we found when I was at UCLA is they had this team member and team leader evaluation form, really talked a ton about career resource management and interpersonal communication skills, but it was almost impossible to fill out when you were trying to be the facilitator in a scenario, give them feedback on the learning outcomes of that actual session, which were usually around presentation of specific types of pathologies. So we were doing a case with DKA, and we were really more concerned about recognizing the signs and symptoms of DKA, the complications of DKA, and then applying the right Southern California specific treatment protocols. But the evaluation sheet on being a team leader was all about management of a scene. And we never even set up a scene. It was in a classroom with a mannequin that wasn't talking, and there was nothing for them to manage. They didn't have to transport. We didn't even move to a fake ambulance. So that evaluation sheet, while it was designed for any simulation, was really not appropriate for the type of simulation that we were doing, which would be a formative simulation only involving part of an EMS call, not even the point to transport. So we started developing more tailored evaluation tools to really measure what we're doing in that simulation and that learning outcome that we're trying to get at. And then are your learning outcomes for the learners, or is it for your program? Is it for your agency? As I mentioned, this maybe is something that you're developing for continued competency or for a CE program that you're trying to get away from. Maybe just watch a video in the background of your screen, and then answer a couple questions that don't necessarily make you have to watch the video kinds of CE programming, which I would love if people went to Sim for CE. But when you're thinking about that outcome, how is it going to drive the specific things that happen in your simulation? So if you are specifically looking at something for the use of a video laryngoscope, you're probably going to make every case that you're building, every sim, related to that. And it might be that your first couple are easy, no complexity, just can I use the equipment? And then once they can actually demonstrate the skill, you might add in the complexity of, do I know if I should choose this particular device or another device? Have I been able to adjust my backup plan for something? So then you add in those complications and you add in the noise to the sim so that you can reach your agency goal. But here's our warning, is there noise just for noise sake? So just because you can add complications doesn't mean that it might be the right thing for the learner or for your learner outcome. I use the example a lot of, if you're just trying to add realism in by adding a barking dog or just noise in the background, is it contributing to the outcome that you're trying to get at? Or is it challenging your learners at the right speed? So if this is an EMT class and this is their maybe second time really practicing medical assessments, do they need something that is going to be challenging them by having noise in the background? So we're turning on a TV in the room to simulate real life, when these learners still aren't even able to ask all of the sample history questions without really struggling. So if their cognitive load is overwhelmed just by performing the task at hand, we probably don't need to add in noise or complications to increase fidelity. All it's going to do is take away from the actual fidelity of our case, right? So if they can't actually interact and ask the questions we want about getting a history, right? They don't even know what questions you would ask to differentiate ischemic chest pain from musculoskeletal chest pain. Adding in an angry family member or overly concerned family member, or having the patient be non-compliant and either aggressive or dangerous, is changing our learning outcome. So for that simulation, now we've added in a layer of dealing with an unruly patient when really the learners need to just get through asking a sample history. So that's one of the things to think about. Sometimes noise is cool and fun, and sometimes adding a bunch of moulage is great. Other times it's just taking away from your actual objective in your sim. So here's that fiction contract where we're really saying to the students, hey, we're trying to make something as close to real or transfer as we can, but it's not always going to be real. And we know that the students are going to infer and put on the level of realism that they are able to get out of what we've tried to do, which sometimes can be really frustrating for us as educators. Were like, man, I did such a great job. That was so realistic. And the students are like, yeah, I don't get it. I don't think it's real. And you're like, no, but I worked so hard. Like, look at all the time I spent building this great scene. I think for us to go back and remember that not every single aspect of the simulation has to be as real as possible. When we think about what fidelity actually means, it's trueness to what we're trying to simulate. So maybe the arm that is with the mannequin that's super fancy is terrible at starting IVs. And we really want to practice something that is going to give them a more realistic experience starting the IVs. So let's use a different IV arm, right? If we're not necessarily worried about the feel of the needle going through the skin, that's not the level of fidelity we need. We really are trying to focus the simulation on, can the student have an appropriate interaction with a patient while starting an IV? Now we go away from the IV arms and we just go to a simple pad, something that's can be Velcroed onto someone's arm and be made in a couple minutes. I believe Tim Reitz has a great video about how to do this. I think on NAEMSE's resources, right? Like, it's not physically high fidelity at all. It's really low fidelity. But if we're looking at the emotional experiential fidelity of having that actually attached to a shoulder that they can't like just turn whatever direction they feel like to get the IV, that might be where the sim goes. So we think of our physical fidelity of getting them through the push and the motion of the different angiocaths, and then we change to our next simulation to add in the, can you talk to a human, and can you position yourself around an arm that's actually attached to a body? So then that's the second layer that we add on in the simulation. And then once they can do that, then now we're taking that skill and putting it into the context of being a team member when something else is going on. So that team member, who we sometimes just ignore when we're building sims, we're all about the team leader and what are they going to do and what's their treatment pathway. But maybe your geriatric stroke got to check that box on the student minimum competency matrix, right? That case is where you add in a third layer to your psychomotor skills, teaching and training, and that team member now has to start an IV on a person who is got really difficult to see veins or is not wanting to move their arm because they have arthritis and it hurts. And so that's the next layer, the next scaffold for IV starting simulations. And it's embedded in something else that you're using for a learning outcome for the team leader. So it's kind of what we're thinking about with fiction, contract, and fidelity. So this is from the Center for Medical Simulation at Harvard. Those folks are just amazing. If you ever have an opportunity to see them at a conference or take their classes, it is well worth the investment. I've been very fortunate to be able to find some grant funding to have them go to their training and participate with them on a bunch of different projects. And this is something that they use to kind of frame this idea of building a simulation program so that you can be ready for whatever. And here's, I just use their example, their model as for assessment. And I think the thing that really helps when I'm thinking of, I want to do a simulation where a student can properly assess and diagnose. I'm going to use DKA. That's the one I have on my brain. DKA. So a paramedic student can do DKA and be ready to treat that patient no matter what. Well, what skills do they need to have? What situations and contextual knowledge do they need to have before they can do those things? And so you think like, okay, well, if they're going to treat patient DKA, they need to recognize the signs and symptoms of hyperglycemia, which would mean that they need to know how to do a physical exam. They need to know how to do a primary assessment. They need to know how to read EKGs. They need to know how to take vital signs, do patient interviewing. They need to understand maybe lab values, just depending on where you want. So you can come up with all of these building skills and each key situation that they might have to have. So I'm thinking if we're working with DKA, they might need to know how to do this on an unconscious patient. So someone who's already unconscious and not alert, how can they assess that person? They're probably going to need to do it on someone who's got altered mental status. They might need to do it for somebody who has a history of diabetes or an unknown medical history. So those are going to be our key situations that helps then determine what simulations, what psychomotor skills labs do I need, what simulations do I need before I can actually introduce this very complex, awesome, cool case I have of a DKA patient that is also got hyperkalemia and potentially ST segment elevation, all stemming from their acidosis. Thomas, this is from the Center for Medical Simulation at Harvard. It's Harvard CMS, and it stems from one of their faculty members' work on sim zones and readiness planning. So yeah, really great tools. All right, so let's look at some examples of how we could scaffold. And I'm hoping that you, lovely people out there that I can't see, are thinking of things that maybe how you need help with simulation or scaffolding in your program. So if you have an example or you have a what if, or hey, how would I do this? Please drop it in the Q&A, throw it up in the chat, and let's make this more interactive than just me talking about things that I've done. Happy to share, but I think that sometimes when we all interact, we can come up with an even better response than maybe what I could just sitting in my apartment here in Los Angeles. So please feel free to chat away. One, you're probably familiar with this picture. It's the summative scenario lab template, and I believe it's like part of the National Registry's resources for the integrated out-of-hospital scenario, and it's about 4 pages long. I find it to be very difficult to work with, especially if I'm trying to do a simulation that I haven't done before. So if you are familiar with the National Registry Psychomotor exam, if you're in this station, they have you look at the scenario for an hour so that you understand where everything is, what's going on, what's expected, how it's going to unfold. I don't know about most EMS programs, but I'm going to hazard to guess that people don't have an hour for every scenario to be reviewed prior to being given, especially the way that I've seen a lot of EMS skills training go, where it's like, all right, you're going to do your adjunct instructor or your lab instructor for the day shows up maybe half an hour before the students are coming and they're getting their information there, or we've emailed it out to them, but they were on shift and they didn't open that email because it went to their school email, which they never check, or they just didn't have time because this is like a side hustle for them, not a primary job like it is for maybe the educator who's trying to plan the day, and they're not even sure what the scenarios are. Or you might be in a program who's just giving you direction of, you know what, you have cardiac scenarios today. Just make sure you cover cardiac and shock scenarios with the students, whatever you want. I'm sure that you're a smart, experienced provider. You've got tons of cases in your back pocket. Sure, I have run a lot of cardiac and shock cases. I've done a lot as sims, but it doesn't really give us an indication of what outcomes do the student needs to walk away with. Because if you say I have an hour-long session with 10 students, we're going to rotate 5 times. And so in 5 hours, you should get 50 students to complete cardiac and shock simulations. It's so wide open that you could go in a bunch of different paths, and maybe some of the groups will get primary assessment out of it. Maybe some of them will get how to differentiate a STEMI, but another group might just get the difference between the presentation of a neurogenic shock and a hypovolemic shock. So I'm not a huge fan of templates that are really, really long, and I'm not a huge fan of no template, nothing. I think we need to find a happy medium in between and really gear that towards what we're trying to learn. So this is an example of a sheet that my lovely colleagues and I, when I was at UCLA, made. And this is for a skills testing that I don't believe they're actually doing anymore, but it was a kind of like checkpoint in the program where the students had learned most of the paramedic level skills that like thinking about IVs, IOs, airway management, and medication administration. And so those skills were already checked off individually. They had had peer feedback, they've had instructor competency check, and now we're giving it to them in a specific scenario to test contextually, can they do that? And can they do that with the added cognitive load of having to interact with each other? And so that's what we're thinking of, like, hey, the reason we're doing this is because they're going to the clinical environment. They're going to be going to hospital, and we need to make sure they're safe and that they can perform this. Because, you know, someone could do a really, really great job of drawing up medication when I give them just the little medication skills bin, and it has just the things that they need. And I tell them, hey, just draw up the adenosine. They're like, no problem, I can do that. And then when they're working as a team member, having to have team dynamics on a patient who also needs airways managed and the access hasn't even been established yet, it's adding cognitive load. And we know that when we add cognitive load, people make mistakes. An example I can give you very clearly is we had a student who was literally one of the top performers, study officer, aced everything. Every instructor said that she was perfectly fine at everything, right? It was one of those, oh, she doesn't need extra practice, she can leave early, she's got it. Put her in the middle of a scenario as a pediatric seizure. She's working as the team member and just starts pulling up every last drop a versed from all of the vials in the box. I'm just watching, I'm like, man, she is gonna either really murder this plastic child or she's doing something crazy. I can't figure it out. And she just lost sight of what she was doing. So because she was trying to talk to her teammates and answer their questions about the management of the patient, she had lost focus and just was pulling up out of all the vials, realizes she's got like 3 or 4 times the amount of medication and corrects the mistake. But it was something we had never seen her do when she was just practicing that skill out of context. So we created this. It's just a scenario. We know they're going to be working in a team. They're going into the clinical setting where they will have a physician, a nurse, a tech, a whole team of people who are already making the decisions about what's going on with the patient. And they are providing very specific, you will do this, paramedic student, please do this. So that's what we created. We created that scenario for that specific learner group. And you can see it's quite short. They're not doing any assessment. That is not what this is about. I shouldn't say not any assessment. They're doing their primary assessment and they're reassessing their interventions. But our evaluators are really looking at 3 things. And we had multiple evaluators in there since we had multiple students being tested or checked off at the same time. But hey, airway management, are they successful or unsuccessful? And they need to be able to perform the skill competently. I don't necessarily care what their backup plan is. I don't necessarily care how they ended up, what method they ended up to manage the airway. I just care that they've done it competently at that point. And then establishing an IV or IO, whichever one is appropriate. And that's what we were measuring there, not specifically like a whole check sheet of they did this, they did this, they did this, they teared their tape first. But I'm sure you guys are aware that there's a million different ways to start an IV. Half of it depends on what equipment you have with you and where you're going, and the other is all style points. So we got rid of the entire checklist about style points and said, is it a competent or an incompetent IV attempt? So, and then same for medication administration. So Richard, your question is a recommendation for having an interesting yet educational simulation for CME and volunteer providers. So I think if that was like the question that I had is, I'm going to be doing a simulation with some volunteers and I want them to get continuing medical education credit for it, which I think anytime you're doing any work, trying to get better at your craft or make the system better, you should be getting credit. So that's awesome that you're offering it. But I would look at, is there something that the department needs? Is there a specific Q&A fallout? Like, so do a needs assessment. Is there something we really need to address to make our providers better? And then if you're like, well, no, or yeah, we've already got that covered, we just want something really fun. I would say take a case that's interesting, and because this is my particular area that I'm interested in right now, look at something that is maybe a slightly different presentation that we miss because we're not always super diverse. So I would think of maybe a presentation of chest pain in a female patient, right? Or specifically, I would think about a large, well-endowed woman with diaphoresis, and the 12 leads, especially V5 and V6, won't stay on. And so they keep popping off. And potentially this is a STEMI or another myocardial infarction event, and you're using a LifePak 15, and it would be printing automatically when the ST segment changes, but because you have poor connection and you're not carrying diaphoretic electrodes, that's not working out for you. So you have to be aware of this equipment kind of failure limitation. That's something I would think of, right? Now, all of that sounds really cool and really interesting, but do our providers know that the LifePak 15 will print out a 12 lead if the ST segment changes, as long as the 12 lead cables are connected? If the answer to that is no, then we got to start back up, and let's just do a simple sim where while they're transporting, all of a sudden the LifePak spits out another 12 lead. And then we can be like, oh my gosh, what happened? What's going on? Let's work through this. Why would this print out? What's changed? What's different about it? So I would start with like this really awesome case that I think is going to be great, and then work backwards and be like, well, would they know to do this? Because if you're setting up a really awesome case, but the learners aren't going to be able to get to step 2 of the 27 steps you have planned, it's not going to be really awesome. It's going to be overly challenging. When people get overly challenged, they start having a decrease in motivation, and you're going to end up having way too many things to try to debrief on that you may never even get to the core learning objective that you want to do, because you're going to be like, okay, wait a second. I don't actually know what peak T waves are. This literally happened to me the other day. Tried to do a DKA case with cool EKG changes that I thought was really interesting. The learner group that I had no idea how to interpret a 12 lead. So my peak T waves that were super cool were just completely lost in the sauce. So we ended up having to ignore all of that fun stuff and just talk about, hey, well, you noticed that it was hyperglycemia and you started fluid. Let's talk about fluid management and how we would ensure that we get enough fluid on board here. Maybe one day we'll get to the peak T waves. Not today was not the day. So hopefully that answered the question good. Got another big one here. Let's see. So Maria, sim program is for CE, not initials. And you want to go to the department of running simulations, 2 to 3 hour time blocks. Ooh, it's cold. Yeah, okay. So Maria, your situation is not uncommon, where you're coming in, you're not sure where the learners are at, you're not sure where the equipment is, you're not sure if the learners know the equipment, and you want to maintain your credibility and look like you know what you're doing, but you're kind of in the dark about how to set this up. If that was me, I would be very keen on sharing with the learners why, and being like super intentional about why you decided to do what you were doing. And what I would decide to do is in 2 or 3 hours, the first probably at least half hour would be pre-briefing and orientation. And so the sim that we're doing is literally just to show the mannequin's features. So, and I would be 100% honest with them. Hey, we're going to do a simulation and we'll start with a cardiac arrest. So it's going to be a conscious patient who goes into cardiac arrest. Most EMS learners are very familiar with the MegaCode kind of simulation because of ACLS classes, paramedic training, EMS training. We just tend to MegaCode a lot, right? I think we're probably the only group that uses MegaCode in like every sentence, it seems like sometimes when we're teaching cardiology. So I would do that. And I'd say, look, here's what we expect you to do. Give them the answer. So my colleague Chris Krobach says you can tell everybody what you want them to do and what the answers are, and they will still make mistakes in simulation. That is why we do sim, to give people a place to make mistakes, to make missteps, and then figure out how we can work as a system and as providers to not have that happen with a real patient. So we're going to do a MegaCode, and the patient is going to have a 3rd degree heart block from a right-sided STEMI. And after about 2 minutes, no matter what you do, they're going to code. I want you to come in and work through it, and we'll make sure that we understand what the mannequin is doing, what the equipment's doing, and you're going to do this like mini sim. I think that'll help you break the ice. It allows you to introduce the equipment. There's still some learning goals there, but it also gives people a chance to start working together in teams and building a sense of psychological safety. So yeah, are we wasting 30 minutes on a simulation that's maybe not as cool as something else, and we've already told them all of the fun assessment findings? Sure, but we've laid the groundwork for the next simulation we can do. We also are going to be able to model debriefing after that small mini sim. So we'll do our mini sim, learn about the equipment, get any of the questions answered that need to be answered. It's also helpful for us as facilitators to gauge where the group is. Then let's debrief it, right? So then we're going to spend 30 minutes debriefing what just happened, and it also sets people up so that they know how they're going to be evaluated, how the feedback is going to be provided for them. And with adult learners, when you do that, you allow them space to be like, oh, okay, this is what they're expecting of me. I'm not worried about going into a trap, and like, I won't make a decision, I won't perform because I'm not sure if I should or shouldn't. It can really help erase some training scars that exist in simulation too. I think especially in EMS, where we, for whatever reason, have trained our students to not talk unless they're the team leader. So they will sit there, and I had a student actively try to put an OPA in a patient who was conscious and alert because the team leader told them to, and they didn't want to ruin the team leader's testing environment. I'm like, look, I'm testing you too as a team member. EMS is a team sport, and I'm not preparing you just to be a team leader. I'm preparing you to be a team member. And if you're going to act like that as a team member, we're going to have a problem. Now, we could talk all about how an internship, our preceptors and field providers maybe do act like terrible team members as some kind of test for the student, but that's a whole nother can of worms. So that's how I would approach that, Maria. Hopefully that answers your question and gives you some helpful ways to scaffold that. And you said your escape room to reinforce basic skills. Yeah, you know, I actually have seen a whole bunch of people do escape rooms. I don't have their contact information handy, but I know that there's a few educators at Fairfax County Fire Rescue who've done escape rooms. And you know that it was a big thing at the Virginia EMS Symposium, and I think they're putting it on at the Tennessee instructor update. So if you want to send me a message, I'll have my contact information up at the end of the slides. I'll try to connect you with those folks. And then of course, the internet's full of escape rooms too. I think escape room is really fun, especially if you set it up. So I would set up what you expect for them to get out of it. I would probably do a mini escape room. I'm very into the model what you want, and then move to a bigger escape room so that the expectations are really well understood. Escape rooms can also be a really great way of showcasing the sim environment, especially if you have a simulation room or you have a high fidelity mannequin that's a little bit more complicated. Great way of showing all of the different features in a fun, relaxed, kind of low stakes manner. One of the things that I am very, as you can see, I've pulled from a whole bunch of different resources, and I think NAEMSE is a great resource for us. We have the training posts, we have educator groups and Google groups and faculty groups. I think reinventing the wheel is just not something anyone has time for. Most of us have more on our plates in EMS than we have time. If you have a job that you have like plenty of time and plenty of resources, please let me know. I would love to come work with you. This has just not been my experience in EMS. So this is the EM sim cases. They have a whole bunch of emergency department cases that I think that you can take. They're available because the free online access to medication, the group is giving them up. There's all sorts of different ones, and we can tailor them to our learner group. And so I pulled one up as an example. Again, it's going to be a multiple page scenario template talking about how you can program a mannequin, all the equipment that you might need. They're going to be hospital based, but it's something you can at least start with. They're well referenced, and it gives you a place where you don't have to try to come up with everything, right? You can just start taking this down. And I would go through and be like, all right, well, what am I going to use this case for? If this is a case for EMTs, I absolutely think that EMT students should run scenarios on diabetic patients, especially diabetic crisis, right? So hyper and hypoglycemia, it's bread and butter for EMS. We run those calls all the time. So let's take this pediatric DKA case and make it for an EMT, right? And so let's see if I can competently annotate a slide here. If I can find my mouse, there it is. I would just start saying, what things am I keeping, right? So this is absolutely like recognize and treat DKA, great objective for a hospital level provider, but maybe it's not DKA for the EMT. So I'm just going to cross that out, and I'll replace that with hyperglycemia. Now, for my paramedic student, maybe I leave it in as DKA because I want them to be able to differentiate between those two. But at the EMT entry level, even if they're just, even if it's CE for EMTs, I just wanted them to know high sugar versus low sugar. And you may completely disagree with me. I'm just using this as an example. I'm not trying to say that EMTs can't recognize DKA. So, but we're just using it as an example. So they're gonna have hyperglycemia, right? And now they have here is the intubation. Well, I am a big fan of the new joint statements around airway management and how we should be doing airway simulation. And I think that one of the things that they mentioned was having enough simulations that don't have intubation so that we show that proper BLS management of an airway is really actually important. And are we accidentally transferring to practice that everyone should intubate and that everyone should be intubated because the only scenarios we run are intubation scenarios? So I'm going to go ahead and change this for my EMTs and just make it BLS management. So secure an airway. I'm just going to say manage. I'll just change that, manage an airway, and appropriately ventilate a severely acidotic patient. So those are the things I'm going to change. And then what I'm going to do is probably make it easier, right? So we'll go through the rest of the case. And if there's something where her airway deteriorates to the point that she needs to be intubated, that's not going to happen in my EMT scenario. I'm going to save that, and that's going to happen in my paramedic scenario. So I'm doing the work, taking it from an existing case that has all of these great resources. They have the EKGs, they have images, they have the learner tools and information for you as a facilitator already made. You're just going to start slashing things and maybe adding where they're appropriate. And then you're going to just work backwards. So I think it's easiest to start with the most detailed case and then just strip things away. Again, you could run this over the course of your program. So if this is a CE program, maybe you run a really simple hyperglycemic case in your January CE course and it goes well and you're like, great. So now you're going to be thinking, I want to have a really complex DKA case. That's going to be my December one. So in between the January and December case, we're going to run a cardiac case. We do ACLS anyway in June. So in June, we're going to run a cardiac case where we're going to get those building block skills of 12 lead interpretation covered so that when we get to this December case, we've got the building blocks of recognizing hyperglycemia, recognizing EKG changes, and now we can do that really cool DKA case in December and just plan out your CE program so that you have all of those fun things. I'm going to clear my drawings and go ahead and put my contact information up just so that you guys have it, but we've got some more conversations coming in here. So usually start the course with a real scenario, patient with unstable tachycardia, then VF, and then RASC, and let the students treat it. And after completion, OB, introduction to achieving the course objectives, focusing on strengths, weaknesses, what, how, when, and why. Okay, that's an interesting way to do it. I think real scenario, I'm hoping you're talking about like a real case. I think those are great places to draw from. Again, thinking about transferring to practice, this is like my biggest gripe with some of those card courses, especially like the ACLS cases. Everybody does not get a return of spontaneous circulation and post-cardiac arrest care. So I think sometimes we have to make sure that when we're creating a real case, we actually are building in the conceptual fidelity that's there. And starting with a multiple EKG changing event with team dynamics of a cardiac arrest, and then even if you're including like movement to the ambulance and transporting after return of spontaneous circulation, just realize that that's a lot. And when we think about the time it takes to do that, if you're running it in real time, which I would suggest is a really important value to simulation, to run it in real time so that students have the opportunity to have to check back in and reassess and create mental models for remembering to reassess, that you then need to debrief that for probably twice as long as you ran it. So if you're running a 20-minute scenario, practicing for like integrated adaptive hospital or something like along those lines, and a code could easily be a 20-minute scenario, especially if you're going through multiple EKG changes and getting return of spontaneous circulation, that's going to be at least, I would say, an hour-long debriefing. And that's probably the area that we don't plan well enough for. We're like, okay, great, we're going to give feedback. Here's like, you ran a 10-minute scenario, we'll give you 10 minutes of feedback. And we don't get to the frame of reference as to why students behaved the way they did in the simulation, or learners behaved the way they did in the simulation. So just caution that when you're building these cases, every time you scaffold and you add another layer of complexity or another objective in there that you think about how is that going to affect the amount of time that you're doing for debriefing and feedback. Because scaffolding isn't just building up, it's also a way we work back down. If you remember that picture from earlier in the slideshow where the learning outcome was on top of the pillar, it was scaffolded on both sides. So thinking about the models of mastery practice and deliberate practice and mastery learning, all of those great educational tools that NAEMSE pushes out is for us to be as good educators bound in education theory. We have to remember that it's useful feedback, useful debriefing is where the learning is occurring, not necessarily just running a scenario after scenario after scenario. So I would challenge you to think that if your feedback is, yeah, you guys did a great job, all right, let's do another one, that you're losing the value of learning. And the value of the simulation really is in that debrief. So even if it's a very simple case, we need to debrief it well. If it's a very complex case, the stakes are even higher. We need to have a really thorough debriefing there so that our learners are taking away the objectives, the outcomes, and the things that we think are important, the reasons we created and crafted these scenarios, and not something accidental that we didn't intend. I'm going to share another place where I stepped in some mud. This was something when I started working at the community college, I was lucky to have nursing faculty that were willing to come in and work in the EMS program with me. And a shortcut that I had been taking to get students to practice assessment in almost every scenario was, even if they were at a nursing home or skilled nursing facility, the nursing staff didn't know anything about the patient. They had to assess the patient, go through the patient paperwork themselves, thinking like, you know, hey, we're training them for worst case scenario. They need to be able to do this skill. And one of the nursing faculty actually asked me, why is every nurse in every simulation you run an idiot? And I had to think back and I was like, you know, I don't ever do a simulation where their nursing colleagues are smart, on the ball, know exactly what's going on with the patient, and can provide a great handoff. So am I teaching my students that all nurses are idiots? I've never said that, but I've only ever portrayed through shorthand that everybody who they're getting a handoff report from doesn't have any information. And that's not realistic. Now, there's tons of internet memes out there about how terrible handoffs can be from skilled nursing facilities, and we could have this debate and share war stories all night, but think about that when you're crafting your sim, right? So if I am crafting a simulation for a nursing home, maybe the first thing I need to do is a mini sim on how do you take a report from nursing staff, right? So maybe it's a very simple patient presentation. It's not complex. They're not having to start CPR right off the bat, but they just need to get the correct information from the staff. They need to know how to ask for their paperwork, how to ask questions in a way that they're communicating with their healthcare provider colleagues. So that's this first sim we run. It's easy peasy, not complex medical situation. It's all about the interaction and having that building skill that they're going to need to use when we get to a complex case. And so then we do a complex case where there's a lot going on. Maybe now there's a family member there in the skilled nursing facility and they have to add that in. How are you going to talk to the healthcare providers and to the family and manage that while you have a critical patient? If we didn't have those building blocks of how to talk to family, how to talk to other healthcare providers, then that sim would have been lost. We would have been able to get nearly as many outcomes out of it. So we're running up on the end of time. If there's any more questions, I'd be happy to answer them. Here's my contact information. Please feel free to reach out if you find simulations that you tailor to a great case or something, or you turn one of your war stories into an amazing sim. Please share them with me. I'd love to add them up in the training post and